In 2019, we opened the EP Center, and it's a very unique place. There's not another one like it anywhere in the world.
I do cases everywhere across the nation, as many of us, and I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology, and they're not purely doing EP.
What has changed is how many patients we can put through the study. Clearly, now most of the studies that we do are in the top enrollment if they are FDA IDE. And that's part of that is the fact that we can fit more patients through the lab because we have more space.
The option of bringing in research is easier, and the option of also spreading the message of what we do is a little bit easier because the new EP space is wired for that. We can transmit to other countries, and we've done that. We've transmitted to meetings all around the globe, procedures that we do here, so that other people can learn and interact across different borders and countries.
Everything that we do is driven by how can we make this more effective, better for the patient, and this go through our own study or collaboration with the industry to push new technologies.
There's been a lot of different advancements. There's been advanced imaging that's come out recently, and now new advanced ablation technologies such as electroporation. And so that's all become interesting. And if you look at our experience here with it, we've already gotten a fairly large experience, in part because of our throughput and our size.
The reason why we push to have a dedicated space is because we strongly feel that that's the best way to provide better care. To have a team that is dedicated to caring patients with arrhythmia, it's really sort of the best environment to have the best outcome.
TCAI is the Texas Cardiac Arrhythmia Institute, and basically that's our group of electrophysiologists that are interested in advancing the field, doing research, and taking care of patients.
I think the people that we try to attract to our practice they all sort of meet the criteria in this commitment to research and innovation, which is really a sort of a strong differentiator of a standard sort of practice in US.
In 2019, we opened the EP Center, and it's a very unique place. There's not another one like it anywhere in the world.
I do cases everywhere across the nation, as many of us, and I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology, and they're not purely doing EP.
What has changed is how many patients we can put through the study. Clearly, now most of the studies that we do are in the top enrollment if they are FDA IDE. And that's part of that is the fact that we can fit more patients through the lab because we have more space.
The option of bringing in research is easier, and the option of also spreading the message of what we do is a little bit easier because the new EP space is wired for that. We can transmit to other countries, and we've done that. We've transmitted to meetings all around the globe, procedures that we do here, so that other people can learn and interact across different borders and countries.
Everything that we do is driven by how can we make this more effective, better for the patient, and this go through our own study or collaboration with the industry to push new technology.
There's been a lot of different advancements. There's been advanced imaging that's come out recently, and now new advanced ablation technologies such as electroporation. And so that's all become interesting. And if you look at our experience here with it, we've already gotten a fairly large experience, in part because of our throughput and our size.
The reason why we push to have a dedicated space is because we strongly feel that that's the best way to provide better care. To have a team that is dedicated to caring patients with arrhythmia, it's really sort of the best environment to have the best outcome. Commitment to research and innovation, which is really a sort of a strong differentiator of a standard sort of practice in US.
In 2019, we opened the EP Center, and it's a very unique place. There's not another one like it anywhere in the world.
I do cases everywhere across the nation, as many of us, and I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology, and they're not purely doing EP.
What has changed is how many patients we can put through the study. Clearly, now most of the studies that we do are in the top enrollment if they are FDA IDE, and that's part of that is the fact that we can fit more patients through the lab because we have more space.
The option of bringing in research is easier, and the option of also spreading the message of what we do is a little bit easier because the new EP space is wired for that. We can transmit to other countries, and we've done that. We've transmitted to meetings all around the globe, procedures that we do here, so that other people can learn and interact across different borders and countries.
Everything that we do is driven by how can we make this more effective, better for the patient, and this go through our own study or collaboration with the industry to push new technology.
There's been a lot of different advancements. There's been advanced imaging that's come out recently, and now new advanced ablation technologies such as electroporation. And so that's all become interesting. And if you look at our experience here with it, we've already gotten a fairly large experience, in part because of our throughput and our size.
The reason why we push to have a dedicated space is because we strongly feel that that's the best way to provide better care. To have a team that is dedicated to caring patients with arrhythmia, it's really sort of the best environment to have the best outcome.
TCAI is the Texas Cardiac Arrhythmia Institute, and basically that's our group of electrophysiologists that are interested in advancing the field, doing research, and taking care of patients.
I think the people that we try to attract to our practice they all sort of meet the criteria of this commitment to research and innovation, which is really a sort of a strong differentiator of a standard sort of practice in US.
In 2019, we opened the EP Center, and it's a very unique place. There's not another one like it anywhere in the world.
I do cases everywhere across the nation, as many of us, and I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology, and they're not purely doing EP.
What has changed is how many patients we can put through the study. Clearly, now most of the studies that we do are in the top enrollment if they are FDA IDE. And that's part of that is the fact that we can fit more patients through the lab because we have more space.
The option of bringing in research is easier, and the option of also spreading the message of what we do is a little bit easier because the new EP space is wired for that. We can transmit to other countries, and we've done that. We've transmitted to meetings all around the globe, procedures that we do here, so that other people can learn and interact across different borders and countries.
Everything that we do is driven by how can we make this more effective, better for the patient, and this go through our own study or collaboration with the industry to push new technology.
There's been a lot of different advancements. There's been advanced imaging that's come out recently, and now new advanced ablation technologies such as electroporation. And so that's all become interesting. And if you look at our experience here with it, we've already gotten a fairly large experience, in part because of our throughput and our size.
The reason why we push to have a dedicated space is because we strongly feel that that's the best way to provide better care. To have a team that is dedicated to caring patients with arrhythmia, it's really sort of the best environment to have the best outcome.
TCAI is the Texas Cardiac Arrhythmia Institute, and basically that's our group of electrophysiologists that are interested in advancing the field, doing research, and taking care of patients.
I think the people that we try to attract to our practice they all sort of meet the criteria of this commitment to research and innovation, which is really a sort of a strong differentiator of a standard sort of practice in US.
In 2019, we opened the EP Center, and it's a very unique place. There's not another one like it anywhere in the world.
I do cases everywhere across the nation, as many of us, and I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology, and they're not purely doing EP.
What has changed is how many patients we can put through the study. Clearly, now most of the studies that we do are in the top enrollment if they are FDA IDE. And that's part of that is the fact that we can fit more patients through the lab because we have more space.
The option of bringing in research is easier, and the option of also spreading the message of what we do is a little bit easier because the new EP space is wired for that. We can transmit to other countries, and we've done that. We've transmitted to meetings all around the globe procedures that we do here so that other people can learn and interact across different borders and countries.
Everything that we do is driven by how can we make this more effective, better for the patient, and this go through our own study or collaboration with the industry to push new technology.
There's been a lot of different advancements. There's been advanced imaging that's come out recently, and now new advanced ablation technologies such as electroporation. And so that's all become interesting. And if you look at our experience here with it, we've already gotten a fairly large experience, in part because of our throughput and our size.
The reason why we push to have a dedicated space is because we strongly feel that that's the best way to provide better care. To have a team that is dedicated to caring patients with arrhythmia, it's really sort of the best environment to have the best outcome.
TCAI is the Texas Cardiac Arrhythmia Institute, and basically that's our group of electrophysiologists that are interested in advancing the field, doing research, and taking care of patients.
I think the people that we try to attract to our practice they all sort of meet the criteria in this commitment to research and innovation, which is really a sort of a strong differentiator of a standard sort of practice in US.
In 2019, we opened the EP Center, and it's a very unique place. There's not another one like it anywhere in the world.
I do cases everywhere across the nation, as many of us, and I always feel more comfortable when I work here because I feel that everybody knows what is going on. I don't have to worry about what they're gonna do because they know what is their role and they're gonna do it right.
The EP Center has 6 EP labs, 12 pre-procedure rooms, 20 patient rooms, which there are 4 suites for our patients to recover after a procedure. It allows us to have staff that are dedicated only to doing EP and providing the best care possible. A lot of EP labs across the country will have some of their techs and nurses will cover cath or they'll cover interventional radiology, and they're not purely doing EP.
What has changed is how many patients we can put through the study. Clearly, now most of the studies that we do are in the top enrollment if they are FDA ID, and that's part of that is the fact that we can fit more patients through the lab because we have more space.
The option of bringing in research is easier, and the option of also spreading the message of what we do is a little bit easier because the new EP space is wired for that. We can transmit to other countries, and we've done that. We've transmitted to meetings all around the globe procedures that we do here so that other people can learn and interact across different borders and countries.
Everything that we do is driven by how can we make this more effective, better for the patient, and this go through our own study or collaboration with the industry to push new technology.
There's been a lot of different advancements. There's been advanced imaging that's come out recently, and now new advanced ablation technologies such as electroporation. And so that's all become interesting. And if you look at our experience here with it, we've already gotten a fairly large experience, in part because of our throughput
welcome back.
And our size.
We're gonna restart.
The reason why we push to have a dedicated space is
Stop the
because
video.
we strongly feel that that's the best way to provide better care. To have a team that.
Okay, welcome back. We're gonna restart with the recorded cases. Dr. Desmundit from Belgium will show us a hybrid approach for inappropriate sinus tachycardia. Please go, and hopefully he will be able to join later.
I'm very honored to be part of this beautiful Congress, and I'm very proud to show our approach for inappropriate sinus tachycardia. As you can see, we are presenting also in the name of Marc Lemaire, our cardiac surgeon, because this procedure was designed to work on the both sides. So that was our publication we did in 2019, and we are more than 7 years working on this procedure. And then we find also a new approach to combine and to solve this problem. The main difference of this procedure is that we do not destroy the sinus node anymore. So we find a circuit that connects to the sinus node that maintain this high heart rate, and we do approach this circuit in a epicardial way. As you can see, where the first cohort was a 50 patient, most women, and that's what I want to show you. We treat all people that they are long-standing problems, so they are not able anymore to work, to have a normal life. The quality of life is completely gone, and then often are women, very young, and as you can see here, the duration of symptoms is more than 38 months. So the point is that they try all drugs possible. So the patient that we refer to this procedure, they are very sick. We are not talking about the temporary condition where you can have inappropriate sinus tachycardia. As you can see in this schema, the approach is to disconnect the sinus node from this new circuit that we find. Anyway, embryologically, you have to know that the ostium of the superior vena cava, the crista, the sinus node, the ostium of the inferior vena cava, they come from the same region and they insert themselves in the right atrium, so they are part of the same structure. And that's make them logically connected. And these are extra circuits that they are able to maintain the tachycardia. As you can see, the map post-procedure, they show the line that we perform without destroy the sinus node. The other paper that we publish is the multi center study, and then we proved that this was and with a new procedure that we designed, and then what came out is that the superiority of this procedure was very high in many point of view. As you can see, that helped us to apply for an FDA trial. Thanks to the help with Atricure, we could succeed to have a single-arm study, because also FDA admit that there are no therapy possible today. So the comparison was not visualize the sinus node, and as you can see here is a multi-screen system, but you can see a normal map of the sinus node. That is, we try to localize the early activation. In the fast start rate help us to have the larger area of the sinus node. As you can see, play with the map. Unfortunately, I can tell you there are no maps that show you the real typical potential of the sinus node, so that you still need to search with your catheter, and you have to look where there are the tail, the head of the sinus node, and where there are the exit. In that way, just we prove the position of the sinus node. Later on, with the surgeon, we will mark this thoracoscopic, and as you can see here, the approach is together. So the surgeon is entering in with the 3-port lateral on the right side, and we are on the femoral access with our catheter to do our map. In the meantime, as you can see, the patient, of course, is sleepy, single low ventilation. This can also give several variation of the heart rate. So the really dropping of the heart rate is the target, but acutely sometimes based on the hemodynamic of the patient could be not really succeed. As you can see, we open the pericardium. One of the things that we saw in the first series of patients that if we do burn a pericardium and if we don't treat pericarditis from the beginning in a prevention fashion, we have a lot of pericarditis in this patient. This young lady, they really show a lot of high reaction of this approach. So they are very sensible. So that was the reason of high pericarditis. Changing our approach, cutting, as you can see here, it's a little bit more tricky for the surgeons, but that reduced drastically the reaction, the inflammatory reaction of the pericardium, and also start medication immediately after the procedure in the prevention. One of the problem in the first paper that now it's solved, and also in the protocol, is something we treat in a preventing fashion to avoid this that was considered one of the minor complications. As you can see, there is a coagulation of the vessel, and then there is a cutting of the pericardium. The pericardium is open on a transversal way. As you can see, lower part of the pericardium is the phrenic nerve running just after a big vessel. And the phrenic nerve is completely protected, it's completely away, and the cut is actually higher and on the free wall of the right atrium. It's a cutting from the superior vena cava to the inferior. Now, as you can see, it's localized. You can see the blue spot, because with the catheter we point where the sinus node limit was, so the surgeon now has a marker that can show the electrical activation of the sinus node, so he knows that when he has to ablate on the superior vena cava, he has to avoid the upper part of this. And then, as you can see, he come on the posterior part, and now he will open the jaw of the clamp, and he will cross the superior vena cava. The change of heart rate, you have to consider that he's pushing on the superior vena cava, so there is a huge hemodynamic effect of closing. But when you clamp, if you clamp too close to the sinus node, you start to see sinus arrest. Junctional and fast junctional are quite normal. Now we try to not get the sinus node inside. As you can see, there is not yet closed the jaw, so they are still deciding where we should perform our ablation. We try to get the atrium out of this. And the most important, that you can see the limit of the SVC. And that's something that you cannot map. If you look the map on the left side, you cannot determine where is this line. But this line is a critical point, so it's really the beginning of the vein. So it's another tissue, another structure. And whatever activity up there can be disconnected from the sinus node, because it's not crucial part of the sinus node. In fact, we find sleeves going up on SVC until the azygos, so they are really huge conditions. As you can see here, one clamp, and then we start to ablate it, keeping the sinus node away. The sinus drop dramatically here. You can see after ablation, even there are moments of junctional. Often the P way is it's change, because of course there is a huge change, but when you do the SVC, you have one of the highest drop of the heart rate in this case. Fast junctional is not a problem, it's typical. The patient is full. As you can see here, to approach the crista, we have to actually desiccate and pass with a lumen tip behind the right pulmonary vein. As you can see here, there is this technique to get this plastic system that will actually help you to pull a rubber guide where you can connect your clamp. You can see it's in the tip. This orange. It guides you the clamp behind the right pulmonary vein without clamp any difficult structure. Then you can, when you put your gel behind the right pulmonary vein, then you can open the other one and decide to. This is an approach that we do because we want to avoid to clamp too close to the sinus node. So including the right pulmonary vein at the moment is the best way to be away from the sinus node. This line, as you can see, it's very distal respect to right atrium, but that we start always like that, and we get closer and closer to the region that we have to ablate of the crystal to disconnect. That is the approaching of the inferior vena cava. As you can see, there is you have to be very careful because you have to look that you are not clamping anything from the left side, like for example, you don't clamp the ostium of the coronary sinus. And then when you can really visualize where the other jaw go, then you can easily get close. You have to always look first where is the other tip. And if you see the orange free and not clamping any other structure on the left side, then you can start to clamp on the inferior vena cava and try to close this circuit. In this specific case, because the sinus node was very lateral, and the area was quite. I have to say that this was a boy of a 19-year-old, and we did few male, so they're not typical patient of this disease. The male, they always have something different. As you can see also in the picture, this is a bunching right atrium. It looks quite sick. You see a lot of fibrosis between the pettinating muscle. As you can see here now, we had to improve the line, and we decided to improve with a catheter. So that's also the nice working together with the surgeons, because we can always improve, and we can also let the surgeons do not take too much risk, because you can always improve this ease line. In this case, it sometimes can happen. It's not typical, but sometimes can happen, and we can always prove the block or eventually improve with some extra ablation. Thank you very much. I hope it was clear the procedure. Every time you are invited in Brussels to see our approach, anytime if you want. And thank you very much for your Congress, for our invitation to your Congress.
Is he going to be joining us?
Yeah, let's go on the Zoom. Thank you, Carlo.
Hello.
Are you
My pleasure. Thank you.
Very nice presentation. So there are a few questions. The first one I have for you is the hybrid approach looks clean and well done, but another way would be to do an epicardial access and inflate the balloon to separate the phrenic nerve. That type of and do endocardial ablation, of course. What do you think about comparing these two strategy?
Thank you for this question. Actually, it will not work for one reason, because I was pointing at the moment the mapping system. We will not be able to show you where the limit of the right atrium respect of the ostium of the superior vena cava is. So it's an anatomical point that by the mapping is not identified, because the ostium of the SVC has a low impedance and there are still signals inside there. So it will be difficult to decide where you draw this line. The balloon will push away a little bit the phrenic nerve, but it will not allow you to do a circumferential lesion. At the moment, we design in that way because in the beginning we want to be safe, and I think it's still early to try to approach in a different way, because still we have to understand what does each movement that we do, because there is for sure an effect on the ganglia that is it's more deep with a clamp than with the catheter endocardial. There is and by the way, including the right vein for technical reason, is also take out some ganglia connection. I will not try to reproduce these in a different way. So I will try to understand this, how it works, and when I have a clear understand what we are looking for, maybe I will approach a different way in the catheter. But if you have a program running, a patient can stay 3 days in hospital and then live quite easy. It's not requiring a huge hospitalization. They are often they are healthy people, so they recover quite fast.
Carlo, I'm wondering, what do you think the rationale for this intercaval line is? How do you think it's helping with an appropriate sinus tachycardia?
Now, the problem that what we did actually, we mapped the tail of the sinus node. And because in many cases, also small case report or whatever, they were showing the crista terminale as an early activation in this patient. And so we disconnect actually the connection that is going on the free wall from the tail without trying to destroy the tail of the sinus node. So we try to keep the sinus node intact, but disconnect in this way. Now this circuit, it seems working. We went stepwise. So we try to disconnect it piece by piece in the first people. So when you have the first patient, and then we have a dropping of the heart rate each time we closed. But when we didn't complete this line, we didn't have the same success rate. The lateral line, what we call actually crystalline, our slang, it's the one that he approach also many of the afferents and the neuro connection to the sinus node, and I think there is the reason they play a big role. At the moment, it took many years to design this. We are checking now with an FDA trial if this real works, is reproducible and everything. in FDA trial fashion, and that's after, I think. In the meantime, we are doing a bench research to try to understand what we do with each lesion. But I'm sorry, it's too early to answer to your question.
There is a question. Can you clarify what was that purple area you said during the presentation? Yeah. How that was created? There is a question I received.
Yeah, sorry. That's to make the movie in time with the slot. I took out how we produce this. Actually, it's very easy. After we map the sinus node, and we recognize the specific signal that they are the topper, the head of the sinus node and the tail of the sinus node. We go with a catheter to looking for this signal, because the map will shift when you enter with the instrument and everything, and we push the catheter just in front of the camera of the surgeons, and the surgeon from the other side he take just a blue of methylene, and he just make a spot on our tip catheter, so to identify the area of the sinus node. That's very easy to reproduce, but it's a landmark that it's interesting to have when you're manipulated with the clamp and everything, that you have your landmark where the sinus node is. And we just pointing the catheter from inside to the surgeon where he has to mark it. That's quite easy. I took out of the movie because I have to stay in the 10 minutes.
Then another question. Again, I'm the bad guy doing questions, not because I really mean them, but because I have to, stimulate the audience.
Go for it.
Patient selection. Would you, propose this procedure to every patient with inappropriate sinus tachycardia, or you will select them by, the one that mainly have palpitation as the main symptoms? Because we know that many patients with inappropriate sinus tachycardia, they have another component of the disease that, require, psychological treatment, to say the least.
Thank you for the question. Actually, it's crucial because as a typical, these procedures start because you are strangled by the most difficult patient, the one that do not respond of any kind of treatment. I do not I do not suggest a procedure to all my patients with inappropriate sinus tachy. As I show you in the beginning, the first study was people that at least have more than 35 months of disease. But the most important that for me, they need to have a very low quality of life. So it means that they cannot function normal, and there are no drugs to help them to go back on the normal lives. That's a little bit, I know that is empiric, but there are many people taking ivabradine or other kind of drugs, and they get kind of balance. And if they are happy with the life that they have, and they can do anything they want, because many of the patients that I treat in the beginning, they couldn't even work because they couldn't stand a full day of the job. So the point is that we took really the small part of this patient, they feel miserable and they cannot have a normal life. It's a small part of your population. It's not all of them. Many times, a typical example of patient with a slow pathway ablation has a temporary high heart rate that stands for 3-6 months. And normally we don't treat them. We don't even give drugs. And the patient after 3 months, it go back to normal. So I really talk about patients that they have a long history first and reduction of the quality of life dramatically.
Dr. Michaud.
So, I think this indicates that the sinus node itself is not the culprit here. And, if you map these and you watch for P-wave shifts and so forth in these patients, often it's mapped to the arcuate ridge, which would be the area between the right atrial appendage and the SVC. Is it just that this clamping is just the most efficient, best way to get that? Because that's not an easy area to necessarily ablate. With a catheter, it's thicker probably, it's hard to get transmural. Is that the main, do you think that's the main benefit of this procedure, or is there something else going on that we're not understanding?
I think you get the point. At the moment, the clamp approach, I think, is the best to get the real transmural lesion and to avoid to create arrhythmias by leaving some gap or whatever. As Luigi say, it's very clean procedure. You saw it, and you can target the structure that you want to ablate. Of course, you need to have an experienced surgeon. It's not something that anybody can do. I mean, they have surgeons that they are used to do TT, and especially surgeons that do systematically AFib procedure, they can easily do this. But I agree with you. At the moment, with the technology that we have, I think this is the best approach. I can tell you because we try in any way, and we landed with this to be the safer and the more efficacy.
Any more questions? How about you mentioned in the presentation, but it was short for the time that you were assigned, the pre-treatment with colchicine, the pain that they have after.
Yeah.
Can you say more? Because, these are, again, some of these patients, usually they are young female into the allied professional field or with an allied professional component, in my personal experience. And
yes. You are completely right.
They feel more pain than others. So what is your take on that?
I mean, what you say is true, of course, and I can tell you, people that they work often night shift, or they break the day-night rhythm. They are the typical high risk of people to develop this on the long term, and that we have a lot of nurses and allied professional. Now, the problem is that we were surprised. So the first paper you will see, we had a huge amount of pericarditis. And honestly, that was not expected because in the AFib patient where we perform this procedure of thoracoscopic, we do not have this problem. So this young lady, I don't know if it's hormonal because the immune system is very active because most of the time they are between 20 years. So they react very bad. And so they have inflammatory reaction from the day one. So that's really that we start to have a systematic treatment with anti-inflammatory drugs and colchicine for at least the first month. And then we decide patient by patient, respect of what is going. And we decide to stop or continue, so respect how we're evolving. But they are really reactive, very bad on any kind of insult. As I explained, we stop to burn the pericardium with the cauterization. We start to cut the pericardium to reduce the necrosis effect and the inflammatory reaction of the pericardium. And that even help a little bit. So a small decision like that, they could make a difference. So since we do a therapy from the day zero, so the day one, and we prevent the pericarditis, we drop inside the 3-4%, and that makes more sense.
Thank you.
I just wanted to ask anything like I understand the objective drop in sinus heart rate and everything. What about quality of life and things like that? Because as you mentioned, there's a lot of psychological aspects to this.
Yeah. He was asking about other measures of success, like quality of life, et cetera, in these patients, in addition to the sinus node or the tachycardia.
So what we measure is the capacity of effort. So often the people that we suggest to do the procedure are people that are not able to perform any effort. Often we do, for example, at Trendelenburg, they don't go over 25 watt. And even that they have to stop because the fatigue. After the procedure, we do the rehab. So that's a very important point because the procedure himself is not only, is not a solution without a correct rehab because the patient are completely lose any kind of physical condition. So the difference is that after the procedure, they are able to exercise. And then after the rehab of 3 months, we go back to see what is the capacity of effort. And we find out that many of them, they go back on the 150 to 100 watt, like normal age. And we don't look the number. I mean, honestly, your question is very clever because we stop to look at the number. The definition even himself about, if somebody has 98 or somebody 100, if he cannot bike of 20-year-old, there is something wrong. I mean, the capacity of effort, I think, is the main point for me, and I can measure with several points, of course, as you know. 6 minutes walking test, bike test, stress test, Trendelenburg. I mean, you can put all of them. And then you can see that after 6 months, they go back and actually they become full capable to run a gym and do, everything that should be done at 20-year-old.
Do you do pre-procedure testing, like autonomic testing or something to determine whether it's a pure inappropriate sinus tachycardia per se, or if it has a mixed kind of flavor to it? You know, do you think that cardioneural ablation or some other form of combined procedure would be necessary?
Actually, we do have a cardio neuro clinic together with a neurologist, and we screen then from up to down. I mean, before decide that could be the way that they have to take to solve the problem, we exclude anything, and we have a neurological investigation, and we do autonomic test to evaluate what is the level of autonomic system, is that the autonomic system is still can recover, if there is a kind of immunodisease underlying. I mean, we go really deep before decide any step forward for this procedure. Consider that I mean, in our clinic, let's say we follow more than 1,000 patients, and we are ablating only 100. I mean, that's actually the ratio.
Any experience in POTS?
Yeah, now that will be a big discussion. I have my opinion about POTS. If there are neurologists in the room, they will kill me probably. But the point is that the POTS for electrophysiology, let's call like that, because I see many of these patients starting with the kind of POTS symptom. I don't talk about the vasodepressive syncope. I mean, I'm talking about this, but many of them, when they have a kind of paroxysmal increase of the heart rate, they end with a syncope. When the heart rate become chronic high, they are capable, because the chronic vasoconstriction, they are capable do not faint anymore, but they feel like dizziness or whatever. So this kind of patient, I call them a kind of paroxysmal EST. And the POTS definition, it's also open to discussion, because the POTS, for a neurological point of view, and that's I have daily in my clinic with my neurologist. Of course, if we have a clear vasodepression and we have a clear the autonomic system that it provoked the syncope, and the heart rate increase after the syncope, or anyway after the symptoms start, that is a vasodepressive stuff. But when you have a POTS that is starting with a high heart rate, and with a reveal we can record this, and then the patient fade, we perform this procedure in this patient, and they do not have syncope anymore. It's also related probably on the big denervation we do on the right vein. The right vein, I think, play a big role in this patient. We try to reproduce this with a catheter endocardial. For example, we did a cryoballoon ablation of the right vein. It didn't work well like perform this procedure, because after a few months, they have a recurrence of syncope. I still try to understand, but POTS, for me, I mean, it's an open possibility for this procedure. The trial we design, it's only for EIST. If people know, I mean, people are used to treat patients with POTS, they are open of many kind of diagnoses. I mean, it's not simple to define them in a way. That's the reason that also in our population is very small percentage of people.
I think even in the IST, there's something we need to understand, because to echo Dr. Michaud's question about the intercal, I have two patients with young patient, female, with IST, but they also had AFib. And we tried to map the IST, and I have recorded AFib a couple of times in the emergency room, but I ignored it because the clinical tachycardia was IST. But we tried to map and burn. We burned very close to the phrenic nerve, but was really on top of the phrenic nerve, so we could not do it. But while doing the ablation, she went into AFib. So I decided to go transeptal and to try to do we did 4-vein isolation. But on the right side, I tried to get the ganglia. And while getting the ganglia, the heart rate dropped, and these two patients are really so happy in their life. We really eliminate the problem. Now, was a combination of the ganglia, and because I did a lot of burning close to the phrenic nerve, maybe I went close to the area that needs to be ablated. So I don't know, but the clinical outcome is good.
Or maybe because you ablated AFib.
Yes. No. The patient had inappropriate sinus tachycardia at 120 beats per minute, and she was coming to the clinic every time. Only one time I saw AFib. And then
But,
by burning we induce AFib. So I believe it was AFib. I agree with you, but I have to say, we implanted an ILR. She never had AFib on an ILR. It's a patient before putting on the table, I really didn't want to put this patient on the table because I know that, it's not an easy case. But I waited and waited, implanted ILR. There was no more AFib again documented. But IST, yes. But the day of the procedure, I got AFib. So, of course, I felt happy because I had something to do more than just the IST. Anyway.
no, for sure, what you point is that there are very complex patients out of there, and you have to get time enough to learn from them. I mean, what you did is typical situation, so you can never decide straightforward when you see the patient first day. They require long-term monitoring. I think you have to learn the patient, you have to understand the situation, and then you decide what you want to do. And that's typical because it's not a straightforward diagnosis. So it's not something that if somebody comes with an AV nodal in your outpatient clinic, you can easily put on the table. For sure, they need more time. It is time-consuming activity to search for this patient.
Okay, to stay in time, we really thank you. We see you are in a
Thank you very much.
You are in a sunny place, so enjoy the rest of your night.
That's Brussels.
Yeah, once a year it happened, no problem.
Yeah.
I'm kidding. Don't worry.
Thank you very much.
Enjoy, bye-bye.
Bye.
So we'll move to another recorded cases. We will see a laser balloon case, and Dr. Kennisberg, I think we have a recorded case, but he's here, so probably he wants to present live. It's coming, yes. Thank you.
Hello. Thank you very much for allowing me to present at this unique and very practical, pragmatic meeting. I appreciate it. I'm going to present a cardiofocus HeartLight X3 laser balloon ablation. This is a 56-year-old lawyer who had a secondary prevention defibrillator and finally conceded to an ablation after he got a bunch of inappropriate shocks. We fast forward to the part of the procedure where I'm doing the transeptal puncture. By this time, I've already had access in the right groin, put the laser balloon sheath in the left atrium. The access in the left side is intracardiac echo and a CRD2 catheter, which I use for pacing to capture the phrenic. And we have the laser balloon advanced into the left superior pulmonary vein. Also, prior to this, I've created a 3D electron anatomical map with precision. You can see the voltage displayed on the bottom right screen. The top right screen shows an endoscopic image of the laser balloon cannulating the left superior pulmonary vein. You also see part of the left inferior pulmonary vein beneath, and then you nicely see the ridge between the left veins and the left atrial appendage. What's unique about this technology is that you actually see in situ how the left atrium and the pulmonary veins look in each individual patient, and it shows you things that you don't necessarily see with intracardiac echo, fluoroscopy, or 3D mapping. I will tell you, to date, I've done approximately 250 of the X3 cases since its FDA approval, and about 120 of them have been entirely fluoroless. I mostly use intracardiac echo to be able to determine where the balloon is, how antral the balloon is, how large the balloon is. We showed a minute ago the balloon remote, which can put the balloon up to 41 millimeters for a left common, which I'll show at the end of the video, or as little as 7 millimeters for a right middle pulmonary vein, which I'll also show. Once the balloon is deflated, there's an atraumatic tip that the sheath is deflectable and could be positioned in the next vein, in this case, the left inferior pulmonary vein. The order I typically go is the left superior, left inferior, right superior, right inferior. The reason fluoroscopy is demonstrated in this case was this is filmed as a teaching case, and the laser balloon has, if you see right behind the sheath, a Z marker, as they call it. I call it a hieroglyph. but it tells you the orientation of the balloon. Now, each vein has its own distinct view in endoscopic imagery. So the left superior pulmonary vein with its two branches typically looks like a comma. The left inferior pulmonary vein, is depicted here, looks like the continent of Africa. Now I'm going in the clockwise direction, starting by the carina on the ridge between the appendage and the inferior vein. Right now going behind the blind spot and then continuing. This is 2 times speed for all of our benefit, and I'm providing the energy of 15 watts. This can be done either at 13 watts or 15 watts in the rapid mode. The rapid mode is the novelty that came out with the X3 generation balloon, the 3rd generation. As you can see here, I'm coming up the post. I don't have a nervous twitch. I'm 2 times. I'm coming up the posterior wall to the carina. Green shows you that it's an aiming beam that's on tissue. There's a red beam which shows blood or some pooling of blood. The laser itself is 980 nanometers, which is in the infrared zone or part of the spectrum, just outside the visible zone. And now I'm coming across the carina to complete the circumferential isolation of this pulmonary vein, which can be easily done and routinely done in a single shot. So I beg to differ with an earlier speaker that this is indeed a single shot technology. It doesn't have to be, but it is. Now I'm repositioning under intracardiac echocardiography the sheath. You can see it's in the left atrium, and positioning it to the right superior pulmonary vein. The atraumatic tip is going out into the lung field, as you can see. And unlike cryo, where you first blow up the balloon, the non-compliant balloon, in the left atrium and then push like the Dickens forwards, in this one you blow the balloon up in the vein and you allow it to come as antrally as possible. It's a little difficult to see here, but there is an outer rim and an inner rim. The outer rim is the widest portion of the vein. This right superior pulmonary vein, some say look like a jelly bean. Sometimes it looks like a donut. And now I'm going in a clockwise fashion on the white portion, which is the antrum of the vein. I'm staying away from the blood in the left atrium, which is to the right of the screen, or the center blood, which is down the barrel of the vein itself. The goal, this is a full contact sport. The goal is to stay connected or in contact with the pulmonary vein so you have adequate contact to provide the laser ablation. Now this is the tension slider. It allows me to be as antral or as distal into the vein as possible. Obviously for PVI, I'd like to be antral. And now again, I'm going behind the blind. This time to the left of the screen is the anterior wall. During the anterior portion of the vein ablation, I am pacing the phrenic with my CRD2 catheter placed way high up, as you can see in the fluoroscopic image. The incidence of phrenic nerve palsy or injury from this technology is extremely rare. I don't recall a case in the current X3 rendition of the balloon. And now we're completing the lesion, coming down. You can see in the endoscopic balloon, the endoscopic view that I'm down. I'm pulling back the balloon, and I'm going to be positioning the sheath in the balloon in the right inferior pulmonary vein. The right inferior pulmonary vein, as you see, if my scrub tech will move, has the ability, or it most commonly looks like an eyelid when the balloon is fully inflated. The difficulty in ablating this vein is that it's a very small vein and it's very posteriorly directed usually. Therefore, I typically try to get a low transeptal approach, and I like to be able to cannulate the vein. Now here you see you have good tissue contact. Again, I'm starting on the posterior wall, and I'm going to be isolating this vein also in the clockwise direction. The area where you cannot see the laser beam or the aiming beam is the area which is called behind the blind. If you have good contact, you can simply go behind the blind. You can see the laser beam come out the other side. Now we are inferior in the right inferior pulmonary vein, and we'll be coming out and going up the anterior portion while facing the phrenic, and then again across the carina and completing this vein. So as you can see in this case, this is a continuous case of this patient. There were 4 veins, 3 of which were all isolated in a single approach. I could have isolated probably the left superior pulmonary vein on a single approach as well. Now, some other technologies will require that you are coaxial at all times. With this type of technology, you can make contact with the balloon by manipulating the sheath in the balloon and don't necessarily have to be entirely coaxial. The goal is not to be too distal. The vein into the vein, as you can see, the inner circumferential area that's radio opaque is into the vein. You want to stay away from that. And now the vein is isolated. This is a typical pre and post voltage map created after this type of case. I typically, when I do a PVI, I only isolate pulmonary veins on the first procedure. If they have recurrence, then I'll bring them back. This is a left common pulmonary vein. Again, it will be isolated in a single shot going around the vein. You can see you have good tissue contact, and in under 3 minutes, you can isolate a left common pulmonary vein without issue, blowing the balloon up to as big as 41 millimeters. And here is a right middle. I really didn't have the appreciation for how many people have right middle veins or a lot of branching on the right side until I started using this technology, and this too can be easily isolated with the balloon. Thank you very much for your time and attention. I'll take any questions.
Thank you very much. There's a question already from Dr. Mansour, actually.
So, David, very nice case. Thank you. I have not used this catheter recently, but early in during the clinical trials, I used it quite a bit. And at that time, we were not ablating behind the blind spot because you may have blood pooling or whatever. And I see here you just go without any issues. Has that changed recently? And how do you feel safe about ablating in areas that you don't see?
Sure. So a couple things. First of all, as you can tell in all of these cases, which wasn't necessarily true when I first started using the balloon, because I did use the second generation before X3 came out, is that if you have a very nice amount of white tissue, of the tissue of the vein, and there is no blood, you're not likely, if you go in a circle, to come into contact with blood. If you ablate on blood, you will cause char, or you'll have an error with the balloon. You can pop the balloon, although in this latest generation, that's very uncommon. The other thing is you can pull back the scope, and then you can check behind the blind to make sure that you have good tissue contact throughout. And then you can, quote unquote, play with the laser beam by manipulating the tension slider and rotating the motor so you can see that you have a good arc that you're going around circumferentially on the vein behind the blind before you push the scope back in, the laser beam back in, and then start ablating.
There is a question from the chat. What % of veins are you treating as single shot?
So we actually looked at this data because I'm going to be publishing 100 cases of Fluorolis, and 85% of which were isolated in a single shot, as far as going once around the vein. Now, 95% of patients were isolated, actually 98% of patients were isolated before I did my pre-map. So they were totally isolated.
David, what do you use for monitoring the esophagus?
It wasn't in this case because, but I typically use a Circa catheter, multi-electrode catheter. For the Fluorolis cases, I take a Josephson quad and I tie it with 3 silk ties and then introduce it under 3D mapping to know where I am. And then I can pull it back to right behind the left atrium and see on which side of the left atrium it exists.
And your ability to move, is less than with a focal catheter, for example, move in and out the vein. So if you're heating, what do? You come down on the energy, or to like 8 watts, 12 watts? What do you use?
Okay, so I try my best not to do anything but rapid if possible, because I believe the efficacy is best with rapid mode, because it gives you that contiguous, homogeneous lesion that you want. So then I can move the laser beam proximally by moving the tension slider, or more distally to be more antral. So I could try to circumvent the area of the esophagus. I can change the size of the balloon, but if I were to do that, I would go in another circle, because I don't want to have any gaps if they're off axis, if they're off on the z-axis. And then finally, if I must, then I will use the non-rapid mode. I will give a focal lesion.
And how much energy do you use?
Typically, if the esophagus is right there, I'll use 5.5 watts.
And anteriorly, on the ridge, for example?
On the ridge, I always use 15 watts rapid, yes.
And any data that you have or that are there about the safety profile from the esophagus point of view? Another question from the chat.
I'm not aware of in the MAUD database or in any of my cases of an AE fistula.
When you run into...
I'm sorry to interrupt, but as used as a single catheter. If you're going to start putting RF and other, then who knows?
When you encounter problems with single shot, what are the major issues you run into that prevent you from doing a single shot?
The top three are contact, contact, and contact. I mean, if you don't have good contact to start, then you're gonna struggle. So getting that initial contact, knowing how big to blow up the balloon, to be as antral as possible. If your transeptal is bad, if it's too anterior, if it's too high, you're going to have a problem. So just setting yourself up for success is the best way.
And if you fail to isolate the vein for whatever reason, how do you figure out where the gaps are?
With voltage mapping.
Okay.
So on a advantage, it's always a problem that we don't see our lesion. So seeing your lesion is clear advantage of this device, and everybody will like that. On the other hand, you still need a mapping system, because not all the time you can isolate the vein. You may need to map
2% of the time.
2% of the time.
Could you talk about your learning experience?
There's definitely a learning curve. First 10 cases are rough, but after that it goes down precipitously. And then it's like riding a bike. It's just very easy, and that's what made me last summer take the leap to just go fleuralist with this, which is fleuralist from the groin like they showed in the prior case.
And where do you see this technology going? I mean, I asked the same question, I don't know if you were here, about Helios and cryo, and now this one. When PFA comes in as a single shot or multiple shot, where do you see this technology?
Well, I read an article, it was an editorial in the Heart Rhythm Journal about a year and a half ago that was published that said the best way to deliver PFA is with balloon technology. So maybe they'll throw PFA on this balloon.
I think we have...
If you're antral enough, I think most technologies could. Very low. It's always, I was trained in MCV with Ken Ellenbogen and Mark Wood to do a double transeptal for every case. We only had RF. We started using cryo. I came out and I started using cryo as a single transeptal technique. I translated that into my RF, and now I only use single transeptal.
I guess one of the issues is that if you have a gap, you have to go find where the gap is, right? So then you have to change out the catheter.
Correct. So, which happens 2% of the time in the series, but basically I take the balloon out, I'm flushing while I take the balloon out, I'm observing on ice, make sure there's no air embolism, which is extremely rare. Again, I think that's good catheter sheath technique. Anyway, so take it out, make a repeat voltage map. Oh, look, there's a little connection posteriorly in the left superior pulmonary vein or between the left veins. Okay, let me do a better job there. I reapply, and then I'm done.
you're basically saying you need a mapping system or you don't use a mapping system on a routine basis.
I always use one. That's how I was trained. That's what I like to do. I have no pushback. I don't live in Europe. I have no reason not to do it. But it doesn't have to have a mapping system. It could be. I would accept the 98% acute success rate.
It does take a lot of cases to get to that 98%.
Absolutely.
Quite a bit.
Well, they say 10 or 15. I would say maybe 50. But okay,
The
but
reason I'm saying that is because the
Sorry,
Schmidt and
I'm still-
published the
yes,
series that it takes after 25 you start getting better, but it's really after 50s where you start
Yes.
getting less.
yes.
Well, 50 is a
Let's think about how many
it's a true
RFs we've
number
done.
because
Yeah.
everything that is said for less is probably not true. I think 50 is.
Yeah.
is
Is there any ability to do anything outside the veins? Obviously off-label.
You could likely isolate the left atrial appendage. That is entirely off-label. I may get shot for that.
Has that been done? Has that been done at all?
It could be done.
Yeah, it has been done. Okay, so thank you very much.
Thank you.
We saw another new technology. Thank you. We are gonna move to another recorded presentation, and we are gonna have a case by Dr. Tondo and Dr. Fassini from Milano. They're gonna present a case with a cryo. I think it's a Boston Scientific cryo case. Please go.
Good morning, everybody, dear friends and dear colleagues. Unfortunately, this year I cannot be in Austin for EP Live due to familial commitment. Nonetheless, I prepared with my associate 3 recorded cases. The first one is related to cryo balloon PVI ablation. Then we recorded a case of left atrial appendage closure with a specific occluder, the Lambre. And finally, we are really happy to introduce the dual chamber leadless pacemaker, and we have implanted 2 patients in the last few days as the first implants in Italy and probably in the world. For cryo balloon ablation, we chose the Polar X cryo ablation system. The slide shows the main components of the system. The smart freeze is the console, the polar sheath, the cryo balloon with the single size of 28 millimeter, and then the polar map catheter, which is the multilateral mapping catheter for PV recording. Probably one of the main features of this novel cryoballoon system is the console and the screen, which comprises a lot of information for the operator during ablation. Not only the temperature and the time is displayed on the screen, but also you can mark the TTI, that is the time to isolation, and also the phrenic nerve can be monitored by diaphragmatic movement sensor, that is called DMS, and the esophageal temperature. Needless to say that all this data can be stored in the console and can be exported for clinical data and further analysis. The operator can activate, deactivate the system by himself, and also inflate and deflate the balloon. That means that the procedure is quite convenient and if you will, just one operator can carry out the procedure. Let's move to our clinical case in which we use also the 3D mapping, the arrhythmia 3D mapping system, just to give an idea of the extension of the cryo ablation. And here we have just an example of the maneuvering of the Orion catheter in the right superior and in the right inferior pulmonary vein as to create their anatomy and the anatomy of the entire left atrium. And here we have the baseline voltage map, the left the posterior wall, and the right the anterior wall. There's a pretty healthy tissue in this patient with the paroxysmal atrial fibrillation. Then there is the preparation of the system. The balloon is submerged under the water with the polar map outside, and in this phase we need to inflate the balloon as is shown here, and we need gently to remove bubbles from the balloon surface. And then we are ready to introduce the balloon into the sheath and ready to proceed with the first positioning of the balloon at the left superior pulmonary vein. At your end, you have the EP recording at the top and the screen of the Polar X at the bottom. And here we have a very good pulmonary vein occlusion as it's shown, so I think that we are ready to start the ablation procedure. And you can appreciate that there's a small PV potential, and please note how fast the temperature goes down in the first few seconds. And when we achieved almost 22-23 seconds, the PV is gone and the vein is isolated. We mark with the green dot exactly the time to isolation, and this data can be stored in the console. The application is 180 seconds, just because the TTI is less than 30-40 seconds. Now we are ready to move to the left inferior pulmonary vein, and I like just to underline the concept of a hockey stick maneuver that we usually perform for the left inferior pulmonary vein. And also we like to appreciate the positioning of the balloon, the occlusion rate in the right oblique projection. Already we have a very good PV recording. Now if we move further, we have this example of the cryo balloon in the right oblique projection, and please note that the very good occlusion when the balloon is properly aligned with the main axis of the left inferior pulmonary vein. So we are ready just to ablate, and the PV potential is clearly shown over here. So we move again to the left ablation of the left oblique projection. We move the polar mat catheter back towards the nose of the cryo balloon as to properly record the PV potential. And here we are ready just to start. And please note again how fast the temperature goes down. We have a prolongation of the PV potential, and at 21 seconds already we have isolation with a beautiful TTI. And again, we prolong the application until 3 minutes. Now we move to the right pulmonary veins, and as a policy, we start with the right inferior pulmonary vein. Please note how we manage the sheath and the balloon itself as to achieve a very good PV occlusion. We prefer to maintain the polar map catheter a little bit further down into the vein just to stabilize the cryoballoon, and then we are ready to start the application. There are just a tiny potential on the EP recording, so since we are unable to exactly establish the TTI, we decided to prolong this application for 4 minutes. And here we have just an example of how to perform a pull-down maneuver from the previous positioning. The cryo balloon is positioning just much lower, and we reach a very low temperature around -54, -55 Celsius degree, and then no potential recorded at the very end of the application. And then we are ready to move to the right superior pulmonary vein. Obviously, during cryoablation, the right pulmonary veins, we continuously pace the phrenic nerve, and here you can appreciate the quadripolar catheter at the subclavian vein position. Now, the balloon is positioned at the ostium of the right superior pulmonary vein. We have PV potential beautifully recorded. The occlusion is very good, so we start to ablate, and just we also pace the phrenic nerve as shown in the EP recording. And please note when the temperature achieves -15 Celsius degree, already we have isolated the veins very fast with a very, very fast achievement of the TTI. So again, 180 seconds. So this is, I think it was a wonderful example of how to isolate each pulmonary vein with the novel Polar X cryo balloon. And at the very end, we remap the 4 pulmonary veins. Here we have the example of the voltage map with the antral ablation of the 4 pulmonary veins. I think I'm done, and I stop over here, hoping that this was beneficial for the further discussion. Thank you.
I think Dr. Tondo is not going to be available for live comments for a family obligation. So if anyone has any experience with this catheter and you want to say something, please step up.
We have Amin also that will make some comment. I mean, we saw a live case at the Milan EP Live with this similar to the Medtronic cryo. This is the now Boston Scientific cryo, has a good console. I think we wanted just to show the availability of this. I don't think anything that we have already commented about, the energy or, the balloon versus the point-by-point ablation. Want to say something? I mean.
I would say the big difference is the pressure change in this balloon is different. So the cryo changes pressure, and there's a little bit of pushback as it does that. So you can have occlusion, and then as you freeze it, push it back a little bit. Whereas this balloon tends not to have as big difference in pressure. That may be the main difference between the two. And notice their temperatures are actually kind of on the lower side of things. But then it may also be reflective of where they're recording temperatures from. So I think it's a good catheter. It's hard to say with PFA coming whether it's going to survive. We'll see.
What about sizes of the balloon compared to the competitor? Because, I would have, I mean, it's a nice procedure, but I would have liked to see a little bit more proximal isolation, especially in the right inferior vein or something. Does it come in different sizes?
I don't think it does. I think it's a similar size profile as the Medtronic cryo. I don't think it comes in a larger size. I think that's a good point, and that's one of the problems with cryo in general. So people have all these tricks to ablate the posterior wall with cryo. So I think if it's someone who's clearly pulmonary driven, sufficient, but oftentimes posterior wall with cryo is a little bit, takes a little more work, and you're taking a catheter somewhere designed to do that at least one time. So, but it's a nice catheter. We'll see how.
Yeah, I mean, I've used it as well. I thought it's a little easier to manipulate because it's not as stiff. The balloon, you can manipulate it once it's inflated and get occlusion a little easier, I think. It tends to conform to the vein better than the Medtronic version. But, I mean, they're both pretty good. I've had good luck with it, and patients have done well after the ablation. I think some of the tricks you can use are using it more segmentally. For that lower part, what I would have done probably if I'd mapped that, I probably would have just pulled back and pushed the balloon down on the lower edge, and then just wouldn't have worried about occlusion, but just make sure that part of the balloon was on the lower part of the right inferior vein, and then you take that tissue out. As long as you're not trying to get full isolation, you're just trying to get a rim of tissue. And as long as the balloon's on there, it will freeze it and get cold.
Any thoughts on doing insurance freezes here? What about the concept of like freezing and thawing and all this stuff? It's not. We don't believe in that's important anymore. Or?
I think our understanding of that has changed a lot, based on a lot of the work that Wilbur Sue's done. The old generation, the first generation cryo balloon was effective but not great, and it really required a freeze-thaw freeze or multiple freezes. You had to be fairly aggressive with it. The next generation cryo balloon was substantially better, and the challenge there was actually back titrating so you wouldn't end up with complications. So I think some of the stuff he's done was looked at time to effect has been very helpful in titrating the amount of energy. So I think what they did there is very reasonable and probably would be reasonably durable.
A comment I wanted to make is like we have shown, and this probably require a full session on this, but we have some fellows going to work, some industry people, faculty people online. Like we have seen that we have a huge amount of technology out there, and it becomes almost impossible, but for Dr. Mansour that is rich, to have everything in your lab. So you have to pick your bits. It's very difficult to maintain all the technology in the lab and maintain, an agreement with, service agreement with everything. So you really have to decide couple, 2, 3, 4 companies. You cannot have laser, cryo from Boston, cryo from Medtronic, RF with Abbott, RF with, how many technology you can possibly have in a lab, unless you have a 10 lab like here or 20 doctors, but otherwise. And so you really need to select the technology you feel comfortable with your patient. What is your opinion about? Because it becomes really difficult to manage this.
Not only that, if you look at, a lot of people, most of the U.S. centers were using ICE, multiple catheters, some ablation catheter, but then multiple diagnostic catheters. We started with Dr. Gupta, basically a single transeptal, one ablation catheter, that's it. So I think the way things are moving with PFA, et cetera, we're probably going to be doing less, more empiric PVI, particularly first timers. And hospitals, COVID has really knocked out some of the, revenue. And so I think we're going to be under increasing pressure to cut down the cost of our procedures.
That's my impression, because we have problem with production, with the war, and the moment we are living, there are many things that are not available as before, and production of this catheter there's shortage of everything. So we're encountering shortage, increased price, and a lot of tools that we use. So and hospital also want to try to cut. So we need really to make a plan on how to spend our money in our procedure.
Also, from a training perspective, as a fellow, it's hard to get expertise in all of these.
Yes.
And you may go to a place where something you trained in is not going to be available. So it's challenging.
I think it's going to be similar to implantable devices, is it? There are it's the same way it's in implantable devices. You probably may not need to use everything, but I think it's important to have more than one option available to just stay in, on the leading edge of things.
I can maybe give a quick update on the lab.
Yeah, and then I have we have 7 minutes. Give an update on the live case that we are not showing.
Yeah. So the patients that you've seen are all doing great. The convergent case, which was slated as live case, is not going to go. So we try not to cherry pick patients, but we also try not to pick the hardest patients either. We want to show some of these educational. This patient ended up having BMI in the 40s, and they were sort of hubbed trying to get a lariat, and the appendage was kind of lateral, so they struggled to get a lariat before so they ended up with window.
Hello everyone, this is Dheeraj Gupta.
And where they are now is they're just dealing with all that sort of stuff. So I think we're not going to be able to show that case. But it should be a lariat case tomorrow to show.
So, you guys are doing a heroic feast here, so thank you for doing all that. It's a large number of cases, and we know how much it takes to get the lab to do so many cases.
Yes. The battery there. Matt, do you want to show the slide? For housekeeping, I need to, thank all the sponsor, since we have this
Yeah,
5 minutes.
we're getting it back
and
up right now, Luigi.
5 minutes, then we hopefully break for lunch, and
And I have, during the lunch, 1 second that I have.
I think this one is good.
No, this is the charger, right? Yeah. The plug. So 1 second that I have to read this. And if you can show the next the slide with the to thank people. So of course, live events are possible only thanks to the sponsor. So we want to thank all the sponsors that contributed to this event to happen. And again, thank you. And we have many people connected, so for sure this is important. During the lunch, there will be also a lunch product theater section. Dr. Burkhardt will show the new vision, the 4D ICE catheter in the setting of VT ablation. So there's something different than LA closure, and hopefully you can appreciate. And before we go to lunch, if my computer will restart, I have a few slides about the PFA case. Yeah, it's probably shut down. we are having issues, so we'll show you. Let's go to lunch. Enjoy, and we come back at 1:30, right?
Yep, 1:30.
Yes, 1:30.
Thank you.
You stay.
TCAI is the Texas Cardiac Arrhythmia Institute, and basically that's our group of electrophysiologists that are interested